Good day, my name is Imelda Williams. With this presentation, I'm going to give you an introduction to preliminary image evaluation. I've put up this slide just to make you aware that for radiographers, the MRPBA has an expectation that they should be able to identify significant findings and to be able to convey this information to either the referring doctor or to the radiologist. And I've given a link there. It's quite useful to maybe look at that, although you are not a radiographer, or you might not be a radiographer. So how did image interpretation for non-radiologists start? Initially, it started with the red dotting. So here you can see there's a pathology and the radiographer would place a red dot. At that time, it was hard copy images. Now on the system, they would either type in the word red dot or place a red dot electronically. And then it moved on to providing what they called initially a comment. And sometimes it's also called a preliminary image evaluation. And the reason for that is when you did red dotting, you were sometimes the person receiving the images back would be unsure where is the pathology or if there's more than one pathology. Whereas with preliminary image evaluation, you can provide a succinct evaluation identifying exactly where and how many pathologies there are, and a brief description of that as well. So there is a hierarchy when it comes to image interpretation. The first thing that needs to be done is to look at the technical image evaluation, look at the quality of the image, for example, if it is a chest, look at how well the patient has inspired when taking the chest x-ray. And then the next level was the red dotting, so providing a red dot. And now there is commenting or providing a preliminary image evaluation. For other modalities, for example, such as sonography, this is called a technical report. With clinical reporting, that's more based in the UK, where, for example, there is double reporting on mammography images, or where there is supervised reporting. And then the independent or definitive clinical reporting, so in Australia, that rests with the radiologist. So remember that a preliminary image evaluation is not a definitive report, but it merely serves as a guide to assist medical interpretation of diagnostic images. And the gold standards, which is the radiologist report, should always be sought to confirm your image evaluation or preliminary image evaluation of the images. So how should you approach preliminary image evaluation? It's important to be aware that you should have a familiarity with anatomy and then also the spectrum of normality, because there are a lot of normal variations to some of the areas in the body that you can see. And it's important that you first know what is normal to be able to distinguish what is abnormal, and this should be identified on each of the projections that you look at. Don't forget to consider the mechanism of injury, because that can direct you to where the possible pathology would be. And the main thing is to work systematic. So apply a systematic approach, and we encourage to adopt the ABC search strategy. Also know imaging features of pathology, so how do fractures, for example, appear on images. It's not just white, it can be black as well. And then you also need to adopt appropriate preliminary image evaluation language so that you can communicate effectively or accurately what you are actually seeing on the images. And then also to have an understanding of how the finding will affect patient management. So the technical evaluation first starts with the identification. Ensure that the correct name is on the image and also the date as well, and then where the left or right markers are on the image. And secondly, is the correct radiographic body part included? For example, if you look at a long bone, say for example the lower limb, then you need to include the knee as well as the ankle. And then for the projections, sometimes you need to there need to be additional views. For example, if there's a query, a radial head fracture in the elbow, then there's additional views that must be done. Or query scaphoid, for example, then again additional views needs to be done for that. It's important to look at the image quality, so for example the contrast and the density, and you might have to comment on any of the above points I've mentioned. So some of the basic areas that you need to try and eliminate. So if there's very poor quality images, it's important to find out whether this should be repeated to get better quality images. And if it can't be, perhaps because of the patient's condition, then you need to report on that. Remember, inexperience can result in either missing a pathology or overcalling on a pathology, and insufficient care in examining images. And it is where you see a pathology and you are directed and your eyes actually transfixed on that pathology, and you forget to scrutinize the rest of the image, and there might be a more significant pathology that has been missed. The other important thing is to ensure that requests are appropriate. For example, if the patient has a query thumb fracture, then you should not request a hand, because the thumb is not demonstrated properly on hand images. And similarly, it's very unusual for both the ankle and the foot to be requested. So also ensure which one, should it be an ankle or should it be a foot x-ray. So for the clinical evaluation, you need to distinguish what is normal from abnormal, and to determine whether the abnormality is normal. It could be related to age or history or an unusual normal variance. To determine whether the abnormality is truly abnormal, sometimes there might be insignificant findings, for example a calcaneal spur. More important to mention that there is a calcaneal fracture. And then also the significance and relevant further findings. For example, you might see a pathological fracture at a tumor site that is at first presentation. Interpretation terminology is important. So it's important to start with the anatomy and laterality. So mention whether it's right or left, the area, and also which side. And then for long bones, to identify whether fracture is proximal or distal. And if we think about, for example, the pubic rami, to mention whether the inferior or superior pubic rami is involved. And on lateral views, to identify whether the fracture is anterior or ventral or palmar in the hand, or in the foot plantar or volar, and then also whether it is posterior or dorsal. And to distinguish accurately between dislocation and subluxation, where subluxation is the partial articulation, and to have the proper views, a true lateral view, to determine if there is a true dislocation or subluxation. So the descriptive terms are important. So X-rays can appear as a lucency, or as a black line, or as a dense or white line. When describing fractures, determine whether there's been any displacement, which means there's a separation of the bone fragments, and if that separation is relative to the long axis of the bone. And if needed, describe whether the displacement is minimal, moderate, or significant. And then at the fracture point, determine whether there's any bending of the long axis at the fracture point. So you want to look at angulation. And the angulation is stated in terms of degrees, for example, whether there's a 30-degree angulation at the fracture point. So just then an example here of a fracture in the forearm. So trying to describe that. So is there a displacement or is there an angulation? And when you draw a line, you can see that there is a dorsal angulation. You always describe it according to the distal part of the body that has been angulated or displaced. And then some of the terminology is to describe the direction of the fracture. So on the wrist image on the left, you can see there is an increased density. So there's a sclerotic appearance, which shows that that is a transverse fracture. And then in the hand here, we've got an oblique line. And on the digit here, we can see there's multiple fragments, which make this a comminuted fracture. And then on the finger, we can see there's a very small avulsion fracture. So still in describing joint displacements now. So on this image, we have described it according to the distal displacement. So here we can see that the distal digit is posteriorly, and on this one as well is also posterior displaced. Then also describe whether the joint that you're looking at is whether it's a distal or proximal. So normally periosteum is not visible on x-rays. However, we start seeing the periosteum when an excess of bone is produced, and that can be as a response to trauma, inflammation, or neoplasms. So the periosteal reaction that we see here is a smooth lamellar type of reaction, which can be typical to fracture healing. It's really important that you have a systematic approach when you interpret images. So use the ABC search strategy, where you work with long bones, or for example with the hand, work clockwise around the bones. And if you see an abnormality, continue past that abnormality until you have completed your search on the images, so that you can identify any additional abnormalities. And to be consistent is the key. So get into that pattern of having a systematic approach. Remember, there can be variations to normality, and the one book that I would recommend is the book by Keats and Anderson, which is the Atlas of Normal Röntgen Variants, and that may simulate disease, and it's a useful textbook to have in your department. And here's some of the normal variants here on the knee, which can be incorrectly identified as a fracture. And this is a normal variant of a bipartite patella. And on the lateral of the ankle, this is an ostrigonum and not an avulsion fracture, and again can be incorrectly identified as an avulsion fracture. Sometimes there may be incidental findings. So when we look at this image, we can see that the bone looks very different. It's lost some of the density, so it's become very loosened. And on the image, you can see that there is a loosened line running through, and that indicates that there is a fracture. However, that fracture is because of pre-existing condition, and the pre-existing condition in this case is a benign enchondroma tumor, and in the end resulting in a pathological fracture. So it's important when you evaluate your images to determine your sensitivity and specificity. So sensitivity is the ability to recognize an abnormality, whereas specificity is the ability to exclude abnormalities and identify it as a normal image. So in the medical imaging portfolio, you will get more information about this, and you will use the 2x2 table. So you need to identify whether the case that you've reported, if it's a true positive, true negative, false negative, or false positive, and then compare that to the radiologist's report. And this is the 2x2 table. The take-home principles for the preliminary image evaluation. Hopefully, this will provide you a way of interpreting your images. Remember, when you interpret the images, you may confirm or exclude an acute abnormality. But if you see an abnormality, do consider whether it's normal for age, for example, when it's a pediatric patient, and then also consider the significance of that abnormality. As this is a preliminary image evaluation, it does not confirm a definitive diagnosis. So you still need to seek the radiologist to provide you with a definitive report. So here's a crib list for writing your preliminary image evaluation summary. Remember, you need to identify whether you are looking at a left or right limb, for example, and then also when you come to long bones, if necessary, you need to include the laterality, so indicate whether it's lateral or medial. And again, with long bones, if you see a fracture, for example, identify whether it's proximal or distal, and then also whether it's anterior or posterior. And if you think about the pelvis, for example, is it inferior or superior? And thinking about the hand, is the fracture on the dorsal side or the volar or palmar side? And you need to provide a fracture description and make sure that you identify accurately, for example, when you come to the joint, whether there is a dislocation or a subluxation. And when you see a fracture, determine whether it's displaced or whether it has angulation at the fracture point. So some watch points. You need to consider the mechanism of injury, as it can provide you with crucial information as to where you would suspect there might be a pathology, and then apply a systematic search strategy. And as through the presentation materials that you'll receive, it's the ABC strategy that we encourage. And don't forget about the satisfaction of search errors. If you see one pathology, you still need to scrutinize the rest of the image to ensure that there aren't any additional pathologies. Also, when you see normal appearances, be aware of normal variations, because sometimes normal variations are incorrectly identified as a pathology. Also try to eliminate confusion or errors when describing pathology, for example, ensuring that you use the correct terminology with comminuted, where there's more than 2 parts to a fracture, or compound, where there is an open fracture. Remember that fractures can simulate accessory ossicles, and then with avulsion injuries, these normally will have a sharp margin. They are not well corticated, and they should fit like a jigsaw puzzle into the adjacent bone. Whereas with ossicles, they are well rounded and have well corticated margins. So some of the final watch points. Remember, you need to answer the clinical question that's been posed. And if you're too cautious, you might find that you overcall, which can lead to unnecessary additional examinations being undertaken. And sometimes you can become too confident and you do not scrutinize the images properly, which can result in undercalling, meaning that a pathology can be missed. And then also be aware of the indiscriminate use of descriptive terms, for example, such as moderate and severe. So finally, be careful what you say. If you are unsure, consult with someone else or go directly to a radiologist, because remember, sometimes this can lead to litigation, and that is not what we want. We hope that with this unit we will assist you in making more informed opinions and to be more accurate in identifying and interpreting abnormalities or excluding abnormalities and identifying the normal appearances correctly. Thank you.